Hello, this is Dr. David, and I'm going to present to you about acid-base balance and arterial blood gases. During this short presentation, we're going to look at understanding the physiology behind acid-base regulation in the body. We're going to look at both the respiratory system and the metabolic system, particularly the kidney. We're going to look at the use of arterial blood gases for assessment and monitoring. We're then going to look at how do you interpret arterial blood gases and give you a stepwise approach, and then look at a particularly more difficult thing of measuring the anion gap and its importance, and then we'll finish off with some practice examples. So did you know that you eat about 70 to 100 millimoles of acid a day in your normal diet, usually in the form of sulfuric acid? Your pH in your body is tightly controlled between 7.38 to 7.42 pH and relies on hydrogen ions, particularly in the extracellular and intracellular fluid. Acidosis is a pH below 7.38 or 7.35, which is due to an increase in hydrogen ions. And alkalosis is a pH above 7.42, which is due to a decrease in hydrogen ions. Now, there are buffers in the body to maintain a tight blood pH, such as hemoglobin, which is an intercellular molecule, calcium carbonate and phosphate in your bone tissue, and then the hydration to carbon dioxide through the carbonic acid buffer pair. So now we're going to look at the Henderson-Hasselbalch equation that basically can go both ways. If you have an increase in hydrogen ions, that decreases the pH. This drives the reaction on the slide to the right. So there's a drop in the plasma bicarbonate and an increase in the pressure, arterial pressure of carbon dioxide, either measured in kilopascals or millimeters of mercury. This acidosis, a drop in pH, either due to an increase of hydrogen ions or a drop in bicarbonate ions, actually stimulates increased ventilation, which blows off the excess carbon dioxide generated. Carbon dioxide is an acidic gas, and so if the respiratory rate increases, what do you think happens to the pH? Yes, it goes up because you're getting rid of an acidic gas from your body. If breathing is ineffective, slow or shallow, what do you think happens to the blood CO2? So if breathing is ineffective, it's slow, what do you think happens to the blood CO2? That's right, it also goes up. And what do you think thus happens to the blood pH? That's right, it goes down because you've got an acidic gas in the blood system, and so the pH drops and it becomes more acidotic. Now, as we said earlier, when this happens, bicarbonate is basically not replaced in this system, the respiratory system, and so the bicarbonate needs to be maintained at 25 millimoles per litre, and this increased ventilation doesn't replace the bicarbonate ions, so we need to somehow generate more bicarbonate. So, which other organ is involved in regulating acid-base balance, excreting excess hydrogen ions, and reabsorbing bicarbonate ions? Shall we find out? That's right, it's the kidney. And the kidney reabsorbs bicarbonate through sodium bicarbonate. As urine drains through the glomerulus and first enters the proximal tubule, sodium is exchanged for hydrogen. Hydrogen combines with bicarbonate to become carbonic acid. This, through the enzyme carbonic anhydrase, then becomes carbon dioxide and water, which is reabsorbed into the cell, which then again becomes carbonic acid, which is then broken down into hydrogen, which is reabsorbed in the lumen, and bicarbonate, which goes across into the blood, which is also exchanged with sodium. So you get sodium bicarbonate that goes back into the blood circulation.
Another thing the kidney does is excrete excess hydrogen. This is in the collecting duct of the kidneys, and you get two different things going on. In the principal cell, one of the cells in the collecting duct, you have an exchange of sodium for potassium. In the alpha intercalated cell, you have exchange of chloride for bicarbonate. So you've got sodium bicarbonate being reabsorbed again into the blood. But also in the alpha intercalated cell, you have exchange of hydrogen that basically goes across the other way back into the urine, and that can be mixed with phosphate and excreted in the urine.
So in summary, carbonic acid links both the respiratory and the metabolic system. Metabolic is usually the kidney. The advantage of this is that the components can vary independently of each other. If the respiratory system falters, the metabolic system can compensate, and vice versa. The respiratory system controls carbon dioxide in the blood, which is an acidic gas. The kidneys, the metabolic system, can control the level of sodium bicarbonate in the blood, which is a base and a buffer of hydrogen ions. Furthermore, the kidney can regulate the pH by excretion of hydrogen ions.
So now we're going to look at some of the more practical aspects of arterial blood gas. When are you going to take it? So patients who arrive in the emergency department who are hypoxic, maybe they have low saturations, and respiratory failure, this is a good opportunity to take an arterial blood gas. Someone who's critically ill or likely to deteriorate, again you want to know how unwell they are. If they're septic, confused, again you want to know the level of their pH and what you need to do to correct this. If someone is in multiple organ failure, perhaps on ICU, again you may be able to offer bases to help regulate the pH, or maybe change the ventilator to a different respiratory rate to help blow off more carbon dioxide, depending what's going on. If somebody comes in as a diabetic ketoacidosis with uncontrolled diabetes, again you want to know if there's a metabolic acidosis and if there's an anion gap and how unwell they are. If someone's taken an overdose or toxin that potentially could cause a metabolic acidosis or alkalosis or respiratory acidosis, this is again a need to take an ABG. But remember, don't just take an ABG unless it will change your management. Taking an ABG is painful, it's difficult, and it's not something to take lightly. If you have ever tried to take an arterial blood gas or will in the future, you'll appreciate this joke as how difficult it is to take an arterial blood gas. So, what does a normal arterial blood gas look like? Well, the pH should range between 7.35 to 7.45. The pressure of carbon dioxide, arterial carbon dioxide, I think you measure this in millimeters of mercury. Here in Jordan, it's 35 to 45. The PO2 is between 83 or 85 to 100 millimeters of mercury. Bicarbonate is 22 to 28 millimoles per litre, and the anion gap is about 10 to 16 millimoles per litre. So let's look at a scenario, a breathless man. Here is a 60-year-old man with a history of chronic obstructive pulmonary disease, and he presents to the emergency department with increasing shortness of breath. Got fever and a productive cough of yellow-green sputum. He is unable to speak in full sentences. His wife says he's been unwell for 2 days. This man looks like he has respiratory failure. He's struggling to breathe, is unable to finish his sentences, and again, it looks like he's got an exacerbation of his COPD with the symptoms he describes. Here is that man's ABG. Here we have a pH that is lower than the normal range, so we know that he has an acidosis. Then we're going to look at the CO2 because we suspect it's respiratory. And sure enough, his CO2 level is much higher than what's the normal range. He's retaining CO2. So this fits with the acidosis as a respiratory cause because we know that carbon dioxide is an acidic gas. So this is respiratory acidosis. What about the bicarbonate? Well, it's within the normal range, so we're not seeing any compensation. There's no change in the metabolic system at the moment. He is hypoxic. His oxygen levels are less than normal, but this doesn't affect the acid-base balance. I'm now going to give you a stepwise approach to looking at arterial blood gas results. Step 1. Is there actually an acid-base abnormality? That is the pH outside the normal range? If it's higher than the normal range, we know it's got an alkalosis. If it's lower than the normal range, then we know the patient has an acidosis. Once we've decided on that, we need to see step 2, which of the two systems fits with the abnormality. So if it's an acidosis, is it a respiratory component? When we look at the CO2 level, the arterial pressure of the CO2, is it high? Or is it a metabolic cause of the acidosis? So with the bicarbonate level, is it low? Is it dropped, causing a metabolic acidosis? So which fits with the picture? As in, does it tell the same story as the pH? If there's a metabolic acidosis, step 2A, we're going to consider whether it's to take an additional step and calculate the anion gap. This can be useful to tell us a potential cause for the metabolic acidosis and how unwell the patient is. In step 3, we're going to look at the opposite system. So say we've got a respiratory acidosis, we're going to look at the metabolic system. Is it compensation? So if there's a respiratory acidosis, has the bicarbonate level also gone up to try and buffer the CO2? Is there compensation? Step 4, what does the arterial pressure of oxygen tell you? Is it type 1 or type 2 respiratory failure? Now, the arterial pressure of oxygen, as we said earlier, does not affect the acid-base balance, which just tells you whether the patient's hypoxic and if they've got respiratory type 1 or 2 failure. So looking at step 4 in more detail, what does the arterial pressure of oxygen tell you? Remember, this does not affect the acid-base balance, but if a patient has a hypoxemia of less than 85 millimeters of mercury on room air, then this is classified as respiratory failure, although not clinically important unless below 65 millimeters of mercury. So type 1 respiratory failure is defined when patient has hypoxemia in the absence of hypercapnia, as in there's no raised arterial pressure of carbon dioxide. Type 2 respiratory failure is when a patient has hypoxemia in the presence of hypercapnia. That's a raised level of arterial carbon dioxide, and this indicates hypoventilation. So what is the anion gap and what is its use in metabolic acidosis? The anion gap is the sum of sodium and potassium taking away chloride and bicarbonate, and that leaves you with 10 to 60 millimoles of litre. In reality, your cation ions should neutralize with your anions, but we don't measure all the different ions, so that's why there's an excess in this calculation. If there is no increase in the anion gap, if it remains between 10 and 16, when there is a loss of bicarbonate, it's usually associated with a rise in the plasma chloride, and causes of this include renal tubular acidosis or severe diarrhea, because intestinal secretions below the stomach contain a large amount of bicarbonate. So yeah, basically the gap isn't there because there's often a rise in the plasma chloride neutralizing the amount of bicarbonate lost. Where there is a metabolic acidosis and an increased anion gap, this is usually where there's an increased production of organic acids in the body, such as ketones or lactic acid, or a reduced excretion of ketones or lactic acid. Causes of this could include lactic acidosis due to shock, infection, or ischemia of the tissues, or ketoacidosis, often seen in diabetes mellitus when it's out of control, or alcohol abuse. Urates, raised urates in renal failure is also a cause, and poisoning of certain drugs such as with aspirin or metformin or methanol are also a cause. So let's look at another scenario. A 6-year-old boy is taken to the emergency department with vomiting and a decreased level of consciousness. His breathing is slow and deep. He's got Kussmaul breathing. He's lethargic and irritable in response to stimulation, and he appears to be dehydrated. His eyes are sunken and mucous membranes are dry. And he has a 2-week history of polydipsia, of drinking lots of fluid, often affinity for sugary drinks. He's got polyuria, going to the toilet a lot, and he's got weight loss. So here is the result of this young boy. Notice the pH is 7.2, which shows an acidosis. Now, is this due to the respiratory system? Well, no, it's not, because the CO2 is low. That doesn't make sense for respiratory acidosis. It's a metabolic acidosis because the bicarbonate has dropped. So what's happening is that the respiratory system is compensating for this metabolic acidosis. Notice or remember from the scenario that the young boy had Kussmaul breathing, so it was deep and slow, hypoventilating, trying to reduce the amount of carbon dioxide blown off. What about the anion gap? Well, if you look at the sodium level in the results, it's 126, potassium was 5, and the chloride 95. So if you add sodium and potassium together, 126 with 5 is 131. Take away 95, and the bicarbonate level was 10. So that's 105, 131, take away 105 gives you 26. Remember, the normal range for anion gap is 10 to 16. This is a high anion gap because the cause of this metabolic acidosis is a new diagnosis of diabetes with ketoacidosis. Take another scenario. A 12-year-old girl who attends the emergency department after falling and hurting her arm. In triage, she's noted to be tachycardic and tachypneic. She's got a fast heart rate and a fast respiratory rate. She's given some painkillers while waiting to be seen by the doctor. She becomes increasingly hysterical, complaining that she's still in pain and now experiencing muscle cramps, tingling, and paresthesia. So this is the result of the ABG. Notice the pH is high, so she's got an alkalosis. Is it a metabolic alkalosis? Well, no, it's not, because the bicarbonate's normal. But notice the CO2 level is less than the normal range, and this is because this girl has become hysterical, she's got pain, she's tachypneic, she's hyperventilation, she's blowing off the excess carbon dioxide. So in summary, respiratory acidosis is a low pH with a high arterial pressure of carbon dioxide. You may or you may not get a compensation, that's why it's in brackets, of bicarbonate, which will go up. The respiratory alkalosis gives you a higher pH, a lower arterial pressure of carbon dioxide, and you may get compensation or you may not from the bicarbonate levels in the metabolic system. Metabolic acidosis is a low pH secondary to a low bicarbonate. The respiratory system may compensate and you get a reduction in the CO2. Metabolic alkalosis is a high pH with a high bicarbonate level, and you may get compensation in the respiratory system with an increase in the arterial pressure of CO2. So we talked about some of the reasons you might take an ABG, arterial blood gas. You may also consider taking an arterial blood gas for monitoring oxygen for COPD patients, particularly if you're concerned regarding carbon dioxide retention, particularly if you're giving high flow oxygen, as this may cause a hypocapnia, and they may retain carbon dioxide, particularly as you reduce their hypoxic drive, and so they drop off with their breathing, and suddenly they don't have the drive to breathe anymore because they've been hypoxic, they have chronic hypoxia, and this hypoxia has caused them to have the respiratory drive with the CO2 levels. If you suddenly give lots of oxygen, they don't have that hypoxic drive anymore, and therefore they retain carbon dioxide. So often you have a blood gas taken at the beginning of someone in the time of the emergency department, and then you may repeat the ABG after 2 hours of oxygen, high level oxygen, to see whether they're one of those patients that retains carbon dioxide if you give them high flow oxygen. Another reason for checking an ABG is to see whether someone meets the criteria for long-term oxygen therapy. Are they hypoxic enough to have long-term oxygen therapy? And also to check whether they retain carbon dioxide, another reason not to give patients long-term oxygen therapy. Talked about assessing someone, how ill someone is, particularly in the monitoring required. Someone who's had a DKA, do they need to go on ICU, or the anion gap is okay, maybe they're okay in a HDU setting. And if someone's been on an ICU bed, if the arterial blood gases are improving, you may want to consider stepping down the patient to HDU bed. Again, we talked about the use of ABGs on ICU to help correct acid-base balance. You might use a bicarbonate, or you might do something with a ventilator to reduce or increase the respiratory rate, depending what the pH is. So here's a practice example of ABG. Have a go. So what do you think it shows? Do you know any causes of this? Yes, that's right. It's a metabolic alkalosis. Several causes of this. It could be due to a loss of gastric secretions through vomiting or NG tube suction. It might be a loss of colonic secretions, like a chloride-losing diarrhea or a bilious adenoma. Certain drugs, particularly thiazides and loop diuretics, particularly after you stop them, can cause a metabolic alkalosis. Post hypocapnia, if someone has retained CO2 and after this moment you can develop a metabolic alkalosis. Patients with cystic fibrosis and a urinary loss of chloride, that might be caused by high blood pressure, adrenal adenomas, renal vascular disease, glucocorticoid, remediable aldosteronism, particularly when you stop steroids, renin secreting tumor, Cushing syndrome, or licorice ingestion. What about this second question? What do you think this arterial blood gas shows? Do you know any causes of this condition? That's right, it's a respiratory acidosis. So hypoventilation, it can be cause COPD, airways obstruction, chest trauma, drug overdose, pulmonary edema, and neuromuscular disease. So here we have another scenario. A 72-year-old Yusuf Abu Raif, a lifelong smoker, and he takes Ventolin and Spiriva, that's tiotropium inhaler. Over the last 3 days, he's become increasingly breathless and has a productive cough. On arrival in the ER department, he's found to have an oxygen saturation of 75%, so he's put on high flow oxygen of 100% oxygen at 12 litres per minute. His initial ABG is below, and then it's repeated after 2 hours, after he becomes increasingly confused. So notice when he first comes in, before he has the oxygen, he's hypoxic, so therefore you put him on the oxygen, he's got a normal pH, but already he's retaining CO2, so he's got a chronic hypoxia and he retains CO2 at this moment. He's got already some compensation from the metabolic system maintaining his pH. After 2 hours, look what's happened to the pH. It's dropped, it's become acidotic. Yes, sure, his hypoxia is improved, but correspondingly his CO2 level has gone up. It's become more hypercapnic, causing his confusion. And so there's also been a compensation from the metabolic system, increased level of bicarbonate. But this has shown that he's retaining CO2 and oxygen, and we need to reduce his oxygen levels put him on a less flow oxygen, or maybe stop it for a while until he hopefully comes round again. And this is just a summary of the different causes for metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. I hope you found this talk useful. I'll leave you with this slide.